Welcome. My name is Alex Goss, and it is my pleasure to welcome you to today's Community Roundtable and to remind all of us that we engage in these forums under HL7's antitrust policies to ensure appropriate collaboration and information sharing. It's great to have you at today's Community Roundtable. We'll kick off today's session with key program updates before our main event that brings together a panel of representatives from an academic health system and a 7-state comprehensive healthcare organization to provide firsthand accounts regarding how clinicians and their teams are helping to lead the way with HL7 Vinci Project real-world production implementations that enable interoperability and advance value-based care. The panel will share their experiences, including how payers and provider interactions evolved as they collaborated to tackle problems and address pain points with the healthcare system. They will share considerations, challenges, and benefits of working together to establish infrastructure to streamline and automate prior authorization workflows, remove latency, and enable real-time data sharing, ultimately creating win-wins for patients, clinicians, administrators, payers, and technologists. Our presenters include Michael Marchant, Director of Interoperability and Innovation at UC Davis, Matt Schuler, Director of Health IT and Industry Standards at Blue Cross Blue Shield Association, and Samira Singh, Director of Population Health Informatics at Providence. We'll have time for questions after program updates and our provider panel. I encourage you to use the question function in Zoom platform throughout today's event to submit your questions. So let's dive in. We'll post a recording of today's webinar and slides on DaVinci's video presentation page on Confluence. DaVinci's communication lead, Leslie Amoros, will be posting links in the chat box to assist in locating that page and other resources you may find of interest. Please be sure to use the question feature to submit questions, as we limited the chat features for us to push key details to you and to enable you to download the chat box so you can save those links, in addition to being able to access the slides on our Confluence page that have all the links. We've also muted lines to aid our recording quality. So finally, we do appreciate your survey feedback, which we will solicit at the end of the webinar. Regarding our Community Roundtable schedule, our next meeting will be August 28th, 2024. Please note, we will not be meeting in July, as we do believe a lot of folks are on vacation, so we've decided to take a hiatus. Regarding upcoming events, there's a Weedy Summer Forum that's being held August 6th through 7th in Chicago, Illinois, and is a hybrid event as well. You can register at the link provided. HL7 events include the upcoming CMS and HL7 Connectathon, a virtual free event. Unfortunately, registration has already closed, but want to make you aware, if you weren't already, that the event is July 16th to the 18th. In the fall, there'll be the 38th Annual Plenary and Working Group Meeting Plus, as well as the HL7 FHIR Connectathon. The Annual Plenary and Working Group Meeting Plus topic is Building Futures, Bridging Borders, the intersection of artificial intelligence and global FHIR innovation. This Working Group Meeting Plus and Annual Plenary will be held following the FHIR Connectathon, September 21st, but it will be meeting in Atlanta, and registration is open. And encourage you to take a look at participating in this exciting event. We'll have a day and a half or so of Working Group Meeting Plus plenary discussions around AI and global FHIR innovation, lessons learned and community participation from across the world on how FHIR is transforming healthcare. Encourage you to participate in that, and if you have the chance to stick around, there'll be some regular work group meetings and some other events happening that week, so stay tuned for future updates. On this slide, I'd like to start talking about our program updates. And for those of you who may not be familiar with this slide, it helps to communicate the DaVinci use cases and their maturity level. The maturity combines three factors: regulatory drivers, standards development progress, and real-world adoption. These factors inform the color scheme we apply to reflect the maturing levels of least mature to active growth to most mature. So you'll see that color scheme of brown, blue, and green at the bottom that we use in color coding. But then you'll also notice that we have dials in the half moons. Those dials reflect the current status of development for the standard for trial use that's in development at that time. We typically advance from an STU1 to 2 to 3 to 4 to normative. So please be aware that the statuses on this slide do reflect our May 2024 level, and there are a few updates to share, which we'll incorporate into the next update of this slide. But wanted to tout some of the progress that we've been making, including letting you know that we will be removing payer coverage decision exchange from this slide as we've moved that functionality for payer to payer functionality into the payer data exchange implementation guide. We'll also be reflecting the increase in burden reduction related adoption efforts and the patient cost transparency advances for standard for trial use 2 implementation guide, as well as the patient cost transparency piloting efforts, and as well as the publication of the value-based performance reporting implementation guide, which I'll talk a little bit more about in a moment. I'd also like to make you aware that we've added an additional burden reduction call to our weekly schedule. Starting June 21st, we'll have 2 calls per week. So there'll be a new call held on Fridays at noon, in addition to the Wednesday at 11 o'clock Eastern call. The call has been added to better support implementers as they work to implement coverage requirements discovery, documentation templates rules, and prior authorization support IGs, and related efforts to comply with CMS 0057 final rule. Regarding the value-based performance implementation guide, or VBPR as we like to refer to it in shorthand, the standard for trial use 1 has published. This means that we've completed the balloting reconciliation process, incorporated the changes, and published the implementation guide, which is now freely available to all at the link noted on the slide. You can also access it from the Da Vinci Implementation Guide dashboard in Confluence. Please join us in testing the newly published implementation guide at the September Connectathon. To learn more and participate in the value-based performance reporting community, please join the bi-weekly community calls held every other week on Mondays at 1 p.m. We've also contained some contact information if you're looking for additional assistance. Let's talk about Da Vinci's implementation guide roadmap. Each year, the Da Vinci Project creates an overall work plan, including this roadmap reflecting membership priorities. The work plan emerges from strategic planning discussions and informed by member survey results. During late summer, early fall, the Da Vinci membership iteratively discusses their scope of work desires, balanced by budgetary aspects, to determine the scope of work for the coming year. Once determined, the Da Vinci Implementation Guide development roadmap is created. This slide. The sharing of the roadmap is important as it helps you and the rest of industry understand the planned work for the coming year so that you can make your plans to participate and engage in development, testing, and feedback processes. This year's roadmap took a little longer to produce than in past years because we needed to assess the impact of 2 final rules: the Health Data, Technology, and Interoperability, Certification Program Updates, Algorithm Transparency, and Information Sharing, as well as CMS Interoperability Prior Authorization Final Rule, or in shorthand names, HTI1 and 0057. On the bottom part of this slide, you'll see key testing and industry events, such as connectathons held 4 times a year. That can help you with understanding your travel budget and participation levels in testing events. On the top part, you'll see that in Q1 of this year, we assessed the impact of HTI1's update to the United States Core Standard, or US Core, to 6.1.0, and our launch of a new use case, postable remittance advice, as well as the Trebuchet FHIR pilots. In Q2 through Q4 of this year, we'll be advancing implementation guide updates across all of our IGs. with some IGs being updated and released, with others that have more significant revisions being updated and then validated. This roadmap may be updated based upon dependencies among implementation guides as we get deeper into the body of work and the direction that's received by the sponsoring HL7 work groups. In case you weren't aware, all of the Da Vinci implementation guides have at least one HL7 work group that officially sponsors and supports the implementation guides in its pacing through the HL7 ANSI accredited standards development process. Speaking of final rule impacts, the Deputy Technical Directors, Lloyd McKenzie and Yen Harris, along with the implementation guide leads, performed an analysis of the HTI1 impacts and related implementation guide considerations. This analysis has been documented in Confluence. The link is provided on the slide should you be interested in the details. From a big picture perspective, HTI1 has advanced our thinking on IG update cycles and how to handle multiple versions of US core being at play because of ONC's United States Core Data for Interoperability, or USCDI, standards advancement. On the Confluence page, we describe Da Vinci's general strategy around support for multiple US core versions and also provide a decision tree to help use case projects decide the appropriate support approach. We're working with HL7 to advance our thinking, which you can learn more about at the link provided. Da Vinci is a member-driven private sector initiative. We have a governance structure and decision-making practices that are documented in our operating guidelines. This includes holding elections for steering committee representatives, which are elected from our operating committee members. If you were in attendance at the May Community Roundtable, you learned that we have a new steering committee chair, Anna Taylor of Multicare Connected Care. We also have a new vice chair, Ryan Bohuchik of Epic. We also have several steering committee member changes that I'd like to share with you today. Vishali Dubey from Florida Blue Cross Blue Shield has been approved to take over Kirk Anderson's role as the payer representative on the steering committee. Bill Howard has joined the steering committee. He is from eHealth Exchange, and Amy Nefsker is going to continue in her role representing United Healthcare. We are tremendously grateful for the service and ongoing support for our outgoing vice chair, Kirk Anderson of Cambia, and Hans Buttendijk of Oracle Health. We also want to recognize Jessica Bartel for her years of service and her handoff to Amy. The guidance and experience of our leaders is a critical ingredient to our success in the Da Vinci Project, as the steering committee works closely with the Project Management Office to bring to fruition the goals and strategies defined by all the Da Vinci members. Their steady hand, supportive efforts, and collective implementation journeys influence the steps to fulfill the mission of Da Vinci to improve value-based care exchanges and interoperable exchange efficiencies in support of patient outcomes. If you'd like to see the full roster, we have a link there. And once again, would like to really do a heartfelt thank you for the service. And I'm really excited to see that we're going to have continued participation from those who have rolled off the steering committee and are continuing their participation on the operating committee. I've already talked a lot about our implementation guide, development work, and governance updates, but I'd like to now showcase several projects we're working on. First is related to the Clinical Quality Language, or CQL, Questionnaire Support Project. This project is to help address various standardization challenges for complex queries and responses between payers and providers. The ultimate goal is to enable providers and payers to achieve efficiencies through the use of common building blocks, including FHIR questionnaires using CQL. We've completed a discovery project to help frame the effort, and we'll share those results as a launch point for industry discussions. We'll be starting public calls and engagement efforts next week, July 1st. They'll have a standing call on Mondays, 12 o'clock Eastern, every other week. We invite you to participate in these discussions that will produce supportive materials to aid CQL implementers, and you can find the meeting details on the HL7 Conference Center as reflected on the slide. Pilots. For my final slide and project updates, I want to talk about the pilots that are underway. You may recall our March Community Roundtable discussing the trebuchet pilots, interoperable FHIR, networked FHIR exchanges, learnings, and industry reflections. The recording is available on our video presentation page should you have missed the webinar, along with all our other recordings. For the trebuchet projects, which are now a formal part of the Da Vinci Project efforts, were initially focused on clinical data exchange, or CDEX, and prior authorization related use cases, think CDR, DTR, and PAS. But however, although those are our initial focus, all the use cases are fair game as progress is being achieved. Industry is invited to attend public calls every other Thursday at 2 p.m. We have a Confluence page, and conference call details are also available on the Conference Call Center. Our next round of piloting efforts is focused on patient cost transparency. Please reach out to Michelle Galliotto if you are interested in patient cost transparency piloting. Think advanced explanation of benefits and good faith estimate exchanges. We're eager to have your participation and look forward to your outreach. All right, at this point, I'm not seeing any questions in the chat box for us, so I'm going to go ahead and invite today's presenters to come on screen. And I see Michael is here, and let's see if we can get Samira and Matt on screen. Michael, Matt, and Samira are going to deliver some presentations, have a Q&A panel, and then we'll have time for your questions that you submit into the question box today. And so I think I'm first turning it over to Matt Schuler.
Great, thanks, Alex. Can you hear me loud and clear?
I can, thank you.
Great. Alex Goss and Leslie Amaros, just a quick kudos and shout out to your efforts, not only what you're doing in the Da Vinci Project Management Office, but working with Samira and Michael and myself on some Sunday or summer Friday afternoons to pull our presentation together. And Alex, before I switch gears to going into my session and my preamble here, just privileged to be here and excited to have been working with Samira and Michael and a number of our Da Vinci colleagues on Da Vinci, not only for the preparation for this presentation, but working on the initiative and building this incredible community. So Alex, you're going to continue to move the slides. I'll give you the cue when to move them. So the way we're going to work this session, and Alex did a really thorough job preamble, but just want to repeat again, because I saw a lot, about 20 people or more come in after she did some of the flow and the agenda, is I'm going to do a little bit of preamble for those that may be new to Da Vinci. So I'm going to spend time on just laying some groundwork and a little bit of a floor for everybody. So we'll do that. I will cover those bases. We're also going to have a setup from both Samira and Michael about their experiences as providers and leaders in their provider organizations to build out an interoperability strategy that utilizes the FHIR standard and API capabilities to improve the efficient delivery of information in their organizations and in the communities that they serve. So that will be the part two of it. And then the part three will be a conversation that I'm going to have with Samira and Michael. And in full transparency, we did this presentation at HIMSS in Orlando earlier this year, and it was very, very well received. And Michael and Samira were outstanding, and we also had an additional panelist at that time too. So we're excited to deliver this information to you. But what's really going to keep, I think, all of us really satisfied is that we get some interaction and we get some questions from those that are spending their Wednesday afternoon with us. So please don't be shy. Michael's not shy, I'm not shy, and Samira's not shy. So please engage and reach out, and for Alex as well, and to Leslie. So please engage with us as we go through the slides, and then we have our conversation with the questions that I prepared to pitch in front of both of them and ask of them. So excited again to be here. Matt Schuler from the Blue Cross Blue Shield Association. I've had the privilege to be on the ground floor of Da Vinci. We started it about almost 7 years ago before we got our official charter founded and all. But I went into this, as did my organization and the payer community, knowing that this is a marathon. This wasn't going to be something we're going to be able to do overnight. But in order to do that, we really knew that we wanted to take the current landscape of clinical and health data interoperability and exchange out of the controlled chaos that's been happening. I think most of us know that there's some really big problems with health data interoperability. Today, we have those point-to-point interfaces. Things are really continuing to be slowly adopted. We're spending a lot of money of moving information and data, and it's very, very fragmented. So we really want to get to a new position and a new landscape where we're working and operating from a common and consistent approach for utilizing applications and how they're implemented and use of implementation guides and utilizing that API capability. We're going to have directory endpoints that are available. That's happening today. We're wanting to be able to make sure that we're making sure the data is secured and how we're exchanging it. We're utilizing standards. We have patient matching, and we're confident in that matching capability, and that we've got a nice pathway for data exchange, and we got an environment to test that's safe and secure. So we want to go from that controlled chaos to a new model, and that was really sort of the catalyst to the founding community of Da Vinci. And a core to all that is collaboration. We want to get rid of those unique solutions and the customization, where we really want to be able to promote industry-wide standards and greater adoption. And I'm hoping that's why the almost 50 people that are with us on this call today understand that that's why we're here. We're wanting, and that's what you're going to hear from the team from Da Vinci, we're wanting to promote greater use of the industry standards and pick up that adoption and really start having that pace and scale advance at a much quicker pace. And I'm confident that that's going to happen because of the investment and the time and energy from folks like Michael and Samira that have made from the provider sector and community to get that adoption and use and take the risk and challenges. And you're going to hear about that as I interview them this afternoon. Another important piece to our success and with success measures is you got to have some quantitative results. You have to be able to measure where we're at today and what we've been implementing. Are the guides that we've designed and developed, are they being implemented properly? Are we getting the results that we intended to get? So that's just my little preamble on Da Vinci itself. And please reach out within the chat function and the Q&A function, and I can elaborate a little bit more as we're getting some feedback from all of you. So Alex, let's go to the next slide. And Alex, you did a very thorough job on the great discipline of structure, process, and measuring outcomes that we have since the Da Vinci's inception. And it's kudos to the Da Vinci PMO and the team from Point of Care Partners that help us do this. And I'm just going to point out a couple things. Alex did a really nice job of setting up, what we're working on, what we worked on the first half of the year and where we're going for the second half of the year. And I just want to point and put a little bit of a spotlight on some of those STUs where, it's important for the people that are on this call that are participating that you recognize that in June, we've updated the CDEX. Samira is going to talk a little bit about CDEX and what she's done with that. But important to know that we're continuing. It's a standard for trial use. It's not finalized. It's not finished. There's really, at some point you get to the finish line, but we know it's a continuous improvement that we want to continue to improve the standards and the use and the IGs that are supporting those use cases. Additionally, you see there on the STU update for July and August, there's going to be some updates to both the risk adjustment STU and the prior authorization support paths. And Michael and Samira and myself, we're going to go into some of those standards that are being used. And then really important, I can't stress this enough. I spent a lot of time with my resources and my energy here at the association, working with the blue companies, make sure that they're aware of what's happening in those updated ballots. And you see tentatively for the September ballot, really important updates that are going to be taking place. So the product that we produce is better because we get great input from the community, whether it's on the provider side, the payer side, the HIT vendor side, you name it. We want that input in order to lift and elevate the level of performance of these standards. So you see CRD, DTR, PDEX, are all going to have some new content available. So just wanted to put a little spotlight on that. But again, you see what we have for our current year. In addition to my volunteering role of supporting Da Vinci, I also support our finance and our planning committee within Da Vinci. So it's within that group, the members of the community that fund the efforts that you're learning and hearing about today. We're being good stewards of those dollars, helping with the priorities of what we think the industry needs to help us bring interoperability to a much higher level of performance that it is today. So Alex, we could go on to the next one. And this is a really good slide that you're seeing here in terms of just some of the proof points and what we've experienced in 2023, and then what we have in store for 2024. And just a little bit of commentary here is that all the communities and stakeholders need to continue to invest in the work that's going on here. We know that if we do it right here, we could reduce the waste and the spend that's going on. I think there's been a recent study in the last year or so of almost $1 trillion of waste that's been measured that's out there. About a third of that is due to administrative waste. And I believe that's because of some of the stuff that we've not been able to automate and modify those workflows. And we'll be hearing from Samira and Michael about how they've been able to do that successfully. So we're trying to reduce that waste, reduce that burden, so that the caregivers can spend their time and energy where they need to be spending their time. And that's with the patients and supporting their communities so that we get the better outcomes and we have a much healthier population. So there's a little bit of a editorial there, but I just had to throw that out there for everybody. In terms of our proof points, we believe that the work that we've been doing here is going to be foundational, and we've built that base for the next 20 plus years for provider and payer connectivity, utilizing the FHIR standard for API connectivity. So that's really going to have more of that real-time data exchange that the providers and the payers and the members need that information when that information is available. We also believe that we want to have consensus-built implementation guides. So when we mean consensus-built, that is getting input from the vendors, getting input from the payer and those provider stakeholders. And then we have that testing of those tools and those reference implementations taking place. And that's what we've been doing over the good past couple of years, but just wanting to highlight some of the successes in 2023. And then in full transparency here, the work in 2023 is what we wanted to showcase at HIMSS and what we're sharing with you today. It's the work that UC Davis has done, Providence has done, and then our colleague Anna Taylor at Multicare Connected Care has done with one of our Blue plans. And then, as I said, we want to get rid of the waste out of the system, reduce the spend that both our individual members, but also all the folks who have an investment in the healthcare dollars spend. So we're going to take a little bit of a transition here now. So Alex, we could go to the next slide. And with permission from our new co-chair of the Da Vinci Steering Committee, Anna Taylor, we're going to look at some of the results that she's experienced by implementing a number of the Da Vinci use cases, utilizing the FHIR standard and API connectivity, whether it's within her own organizations or other providers in the community or her payer partners in her community. But just some quick highlights and success. A number of these results are quantitative. You'll have some qualitative findings that Anna's excellent at delivering when she makes these presentations. You can go online and see some of those. She's very well published, both in the literature as well as in YouTube and some of the other sources. And LinkedIn, you could see some of her presentations. But some of the results that she measured, Anna's an engineer, a process engineer by education and training. And first and foremost, she was able to decrease the matching error rates when they were trying to build out their rosters for the risk adjustment capabilities with their payer partners in their communities. So they saw a 60% decrease in error rates. So what do we mean by that? That is, you're getting rid of the dupes. You're matching to the right individuals with the right payer and with the right provider. They've also reduced the amount of spend and time it takes to process those matching errors. So they've cut off 5 to 10 minutes, and they're able to do that in 5 to 10 minutes. So really, really improving their performance. And then they're able to retool and utilize those FTEs who are spending all that time on matching capabilities and saving a good percentage of time per the FTEs that she manages, and that we're utilizing rosters to support risk-based adjustment and other risk-based tools. So Alex, let's go on to the next one. So she worked with the ATR IG, then she moved into data exchange for quality measures. And again, measuring very specifically what she was wanting to do. And one of her first metrics was seeing an overall improvement of her quality measurement scores. So she had over 175% improvement from where she was at prior to utilizing this capability. She was able to close additional 48 gaps in care through the use of the DEQM IG. And then really important piece, and that is to get rid of this particular part of waste, and that is all the manual chart chasing that goes on, and getting rid of that spend and reducing that spend of what it takes to track down a medical record and a set of information to either do quality measurement, risk adjustment, care management, or what else is needed there for that particular chart and record that's needed. And then the last case I'm going to highlight for multi-care connected care is the work, and it's I would consider it somewhat seminal work, and these results are going to be published very shortly. You'll see some of the initial work that they did, but as part of the work that Anna did with her payer partner, in this case it was Regence Blue Cross and Blue Shield, they focused on automating the prior authorization, utilizing the Vinci use case instead of IGs. And what they're able to do is, before they were automated, it would take about 3 to 5, they're able to process 3 to 5 prior auths per hour. After they implemented, some number of prior auths were automated. I know Michael and Samara can probably touch on some of that as well, what they were able to see. But they were able to do 10 to 12 process per hour. So they saw almost 140 to 233% increase in prior authorization productivity. So some really good successes. And I allude to the work that both Cambia Regents did with multi-connected care. Is they also not only did that work because they wanted to do that within their community, but they also did it in support of a special exception that Da Vinci received to do and implement these particular IGs, not utilizing the existing X12 standards, but utilizing the Da Vinci FHIR-based standards. The results from that activity are going to be published, and Alex could probably speak if we have some time at the end to talk about what's going to be happening. Is that official report from that demonstration is going to be published, and it has been sent to the CMS. They were the ones that granted the exception. So they were able to complete that report, and it'll be public very shortly. So that's a little bit of a preamble on my end of just sort of setting a little bit about Da Vinci, a little bit of our payer focus, some of the results that one of our payers, Regence Blue Cross Blue Shield, did with a particular organization, and that is multi-care connected care. So Alex, we can move on to the next slide, and we'll transition to some, we'll transition to Samira. She's going to take over here and talk about the great work that she did in working with a clinical data exchange in support of her priorities within her organization. Samira?
Thank you, Matt. Can you all hear me okay?
Very good.
Sound good.
Okay. Perfect. Matt, you did such a wonderful job that before I move on to talking about CDEX, I wanted to highlight that first piece that you talked about around ATR, because I think if you all on the call do not know us, we're very realistic as it pertains to our implementations. Matt, Michael, I, Anna, Taylor, all of us. There's this school of thought that looks at a lot of this work and says, oh, here's how amazing it is. Here's why you should do things. FHIR is great. And then here's this other side, this realistic side where we say, what is the actual impact on our work? What are our goals? To Matt's point, how do we quantify what we're building and so forth? And so I think when we all talk about ATR, so that member attribution use case, I think it's easy to say, oh, you're getting members. Okay, who cares? but it's also so important to highlight how foundational that is to your move towards value-based care. What a lot of provider organizations do right now is they have someone who goes into a portal, they retrieve a list, then they manually match those members in some capacity, or they hire a third party or whatever it may be. But a lot of the workflow is extremely manual. So I think when we talk about burden reduction, we cannot forget about the burden associated with the administration of value-based care partnerships, right? So whereas manually you're going off to an SFTP server, you're going off to a website, you're doing all this stuff. If you implement something like ATR, your retrieval process can be automated. The way that you store your data on a FHIR server can be automated. The way that you perform user acceptance testing or general QA criteria can be automated against the implementation guide. You are truly reducing burden there. You're truly allocating time and space for those individuals who are going off and scraping things manually to be able to work on things that are of higher importance, like it pertains to your value-based care contracts, population health, strategy, whatever it may be. So I always just want to highlight that, because I think a lot of the time some of our things they sound exciting and fun, and really they just have such a real world impact, and that's why we're all so passionate about them. Okay, ATR is amazing. So now let's talk about CDEX and clinical data exchange in general, which is another passion of mine, because in most value-based care contracts, you have a quality component, right? You have something that says you are entering into an agreement with you, perhaps other providers, if you have a high performance network or a clinically integrated network, and you have a payer, multiple payers, whatever it may be. And within that agreement, you have to be able to share clinical quality data to be able to close quality gaps, right? So it could be 5-star measures, it could be HEDIS, it could be gaps related to quality or care management, whatever it may be. And so you need to have a way to share that information in a somewhat automated way, right? To be able to ensure that you are getting the credit for the work that you're doing, to be able to showcase all the amazing things, all the upstream effort that your teams do to be able to close quality gaps, to be able to provide preventative services to patients, to be able to make sure that you're providing healthcare, right? And not just sick care. And so CDEX is one of the ways that we have approached that. Let's go to the next slide, please. So kind of going into this again, so what is supplemental clinical data? Kind of tagging on to the last slide. So typically supplemental clinical data is what providers send or share with their payer partners. That can look different depending on which provider group you're part of, or which payer is sending data to. It might be information that gets entered into a portal, which we know we don't want to do, right? Or information that gets uploaded through a portal. Think about if you have a colonoscopy and there was a historical procedure and you don't have the associated codes with it, you may have to actually take that document and then, or documents if you have multiple patients, and then zip them and upload them through a portal. It could look like supplemental quality data that is automated and exchanged through SFTP, which we at Providence support. Or it can look like CDEX, right? Where you have a bulk bundle that gets sent to a payer partner on an automated process on a monthly basis that will close your quality gaps, right? That again will showcase all the amazing work that you've done, and that will ensure that you and your payer partner have the same understanding of the kind of care that the members have received and areas that you should actually focus on as it pertains to outreach and so forth. So if you look at the right hand of the screen, all the fields that you see there, that's typically what it looks like, right? You're sending information or sharing information around member identification. You're sharing information around what the services were that were performed, where they were performed, by whom, at what point, and so forth. And then for some quality measures, when you think about like diabetes management and A1C tests, you're also sharing the output. And if you're sitting here saying, well, doesn't this information get exchanged through claims? I would agree with you. However, a lot of these quality measures have elongated look back periods, like up to 10 years for some of them. And then to my mention about labs, a lot of that data is not shared, right? You may have the actual CPT code or LOIN code that something was performed, but the actual output or range or value of any sort does not go out on the claim. And so you still have a dire need for supplemental data. Next slide, please. All right, so when we talk about legacy supplemental data, I won't talk about portals. I'm sure you all are familiar with them, but for our payer partners where perhaps FHIR isn't an option with them yet, what we've done over the past years is we've supported a supplemental exchange through an SFTP transfer process. So secure file transfer protocol, there's a server somewhere on the FHIR side, we're able to send information to that location, payer picks it up, and then is able to process it. It all sounds really dandy and fun and automated when until you realize that in order to be able to produce this data, remember I mentioned ATR is extremely important, you need to be able to identify your patient population, right? If you're getting ATR and you're getting information that is kind of the same from all of your payer partners, easy peasy, right? Your match rates are probably going to be high. You're able to develop a single process. But if you're getting a separate proprietary format from every single payer partner to no fault of their own, right? We're all kind of in the same ecosystem. Then you're having to normalize that data. So your first step there is, who are my members and how do I make sure that I have the same understanding of my members across the different contracts? You're going to have to take that information, marry it up with what you have in your EMR, and load it into some sort of clinical data repository or a warehouse. You also have to make sure that you have a very solid understanding of what the quality measures are that are part of your value-based care contract, how they're calculated, think about your HEDIS specifications or whatever the measure criteria is, marry all of that up, and then produce the files for your payers. So even if at this point you're saying, yes, I've got this, I can do all of this. Well, maybe if you have 5 contracts or 10, it's okay. It's easy to maintain a lot of different proprietary formats. We have, I always say close to 200, but I think it's somewhere in the ballpark of about 170 or so right now across 62 different pairs. And not all of them need supplemental data. It all varies on what kind of contract you have. But let's say that you have 50 different formats or 30 different formats, and every single month you're producing that data. And every single month you're performing different QA cycles on all of those different formats. You need a small army to support this, right? And most provider organizations do not have the bandwidth or funds, whatever it may be, to support this. And so if we're saying our goal is to ensure that we can grow within value-based care, that we're moving away from fee-for-service, then we need to have a better way to exchange supplemental data that has such a strong impact on our quality performance, besides proprietary exchange mechanisms, modalities, et cetera. It works right now. For all of us, it works right now-ish. But we know that CDEX and eventually DGM will give us something much, much better. So let's go on to the next slide, please. All right, so we are in production with CDEX right now. I think we went into production sometime last fall. And when you think about this last slide, and I won't go through every single step here, but when you think about this last slide around, you need ATR enrollment data in order to identify your member population. You need a way to query either your EHR database or your backend tables. You need a way to identify what the quality measures are and to be able to package everything up. And then you have to think about all the different formats for export, ensuring that you're meeting all the exchange modalities, all those complications. CDEX is a little bit different in this case, right? A lot different. One, it's a standard, right? You have a standardized way to identify all the different resources. So remember I said you need to identify who your member is, who the practitioner is, who the organization is, what kind of procedure or observation or diagnostic report they had. All of that is standard. So at any point in time between a payer and provider, you're speaking a common language, right? In addition to that, your exchange modality is standard. So yes, you need an OAuth token. Yes, you need to set up your APIs. Yes, you probably need some sort of app gateway and so forth. But at the end of the day, when you implement this once, that process that you see on screen, you get your membership, you go off to the EMR, you patient match, you do your quality measures, you expose the data in a streamlined way to every single payer. After you implement once, the scalability factor is major there. You're not having your conversations around what does the output need to look like? What if I have to data mine for additional data elements? What if I don't have access to that? What if there are issues and someone is manually validating the data? You can validate against the implementation guide. You understand what the resources are and you understand exactly what you're expecting, not just from Providence as a provider, but any provider that implements this. And that's a major one. And I think we talked about, Matt, you talked about why it's so important to be able to reduce the burden, right? In that past slide, I said you need a small army to validate every single different format. This is a single format. You can have people focus on other things, whether it be expansion to new measures, expansion to new implementation guides like risk adjustment, which is absolutely major, especially if you have value-based contracts that are focused on the MA population, right? You can focus on things like prior authorization later on, which all of these things are extremely important. And so once you can set your sight from moving from managing proprietary formats and proprietary exchange mechanisms, you really have the ability to take what you've built through one use case recycle some of that if you build a clinical data repository, and then scale out to all these other use cases that have a high impact on performance, high impact on reimbursement, and in general, high impact on outreach and everything else that's part of population health and value-based care. All right, next slide, please. Okay, so I know this says Q1 2024. We should change that, but this is just an overview of the quality measures that we decided to focus on when we went into building out CDEX. So what we essentially did is we said across our value-based care contracts, whether we're submitting supplemental data or not, we want to take stock of all of the quality measures that are associated with those contracts that are associated across the different lines of business. So commercial, Medicare, commercial, Medicaid, Medicare Advantage. And then we took a look at that and said, okay, what are the heavy hitters? Those are the measures that we identified that were most prevalent across all the contracts. And then we started with our build. We do have quite a few of these that are either in production or are currently getting tested or in QA. And we're absolutely happy to, chat about our process, chat about why this is important and so forth. So please feel free to ask any questions that you may have. All right, go. Okay, so you may be sitting here thinking, well, I've been using portals for a long time, or I've been, sending a spreadsheet to someone, and I know that it works. And is this really real? Like, how can we trust this process and so forth? And there are some things through, processes that I'm sure you're familiar with that will not go away. Like even in this, one of the reasons why our payers trust our data is because we share test files, right? We share test information showing that if at any point you look at our data and you compare it to what you see on the front end of an EHR, it will match, right? We're not changing anything. We do share samples of patient charts through regular processes in partnership with our HIM team and vendors and so forth. We know provenance is extremely important. We know that if you're producing an Excel spreadsheet, that is non-existent unless you do something manually. So FHIR is a big piece there. We do share data dictionaries. We're very involved in this. Like this isn't something where we say, hey, payer partner, take our CDEX data or take it or leave it. We look at what our payer partners are receiving currently. We go through all the data elements. We match it up to the FHIR resources. We talk about what makes sense, what doesn't. We talk about whether DQM is a better option, right? We meet our market where it's at. And we fully acknowledge that throughout all of this, in order for value-based care to be successful, payers and providers have to be equals at the table, right? They have to be able to speak openly. They have to be able to work on common goals. They have to be able to represent the patient population the best way we all possibly can. So we have data dictionaries. We're all heavily involved in the product planning, the execution process, and so forth. And then we also have a history of passing audits. This is something that we're really proud of. We don't change the data, and FHIR is absolutely great when it comes to that. And I also it's not on here, but I also wanted to say that we all know that 100% adoption of FHIR will never happen, not overnight at least. And so we're very realistic in this, right? We say, okay, we know that the FHIR-based data that we have access to through our EMRs is more clinical in nature than what you typically send in supplemental data. And so we're always willing to work with our payer partners if they cannot take those FHIR bundles, if they're still figuring out what their next steps are. We look for ways to support the process on the legacy side through the use of FHIR, whether that be a translational layer or meeting them in the middle or whatever it may be. But the gist of all of this is that trust is created through the foundation that we collectively build together and through the foundation that we at DaVinci build together. Think about all the payers and providers and vendors there at the table saying, how do we ensure that for something like supplemental quality data or risk adjustment or prior auth, we are building a solution that will universally work for all. That's what CDEX is to us. All right, next, please. Okay, and I will pass the baton on to Marchant, UC Davis.
The baton is passed. Very apropos analogy as we're watching the Olympic trials and we're running fast around the track here or swimming in the pool or jumping over stuff, or for those watching football / soccer fans watching the Copa Americana and the European Cup there. All good sports analogies. I'm a big sports fan, so not going to talk about the trifecta, like that's a triple. Basically, what I want to do is share our story about our participation with DaVinci. We've had a number of years as part of the DaVinci family, and really what we were looking for, and I think that the term comes up a lot when talking about this, is the significant administrative burden prior authorization puts on provider organizations in order to get patients the care that they need. And depending on the number of contracts you have and the number of value-based arrangements and the number of covered lives that you're responsible for, the processes could be various web portals, phone calls, faxes. I have a friend named Jack who likes to tout Axe the Fax. Literally in a conference call yesterday, he picked up from his office a fireman's axe. So I don't know what they're doing at Epic, but he actually has an axe in his office. So I guess safety codes don't apply in Verona, Wisconsin. But anyway, that's really what we're looking at doing is implementing technology that eliminates a lot of that burden around the prior auth process. And really our foray into that first started with Centene. I'm going to drop a link in the chat. This is a full video that includes a demonstration from top to bottom of all the technology that we implemented, including walking through the Epic workflow related to, we're an Epic site, so that's why I talked about Epic. But working through the Epic workflow and the technology that we have in place to support electronic prior auth. And I think that what we want to do is work with our operational business owners to implement technology that allows for them to have a seamless, integrated workflow from top to bottom in the system that they use. So here at UC Davis, there's a referral coordinator that manages that referral process. And by leveraging the Da Vinci implementation and the data exchange, the DTR and the PAS and all the acronym soup, that if you peruse the websites or peruse the internet, you'll find all that information. Or if you're a fan of AI, just go prompt it to look for the Da Vinci DTR or the Da Vinci PAS, and you're good to go. So the first use case was with Centene. We implemented 5 of those use cases, and that's the video I dropped in the chat. And really that allowed for the referral coordinator real time to submit an authorization, get that information over to Centene, which was our payer partner at the time, for them to adjudicate that request and then send back a response. The interesting thing, and in the demo you'll see in that YouTube video, you'll actually be able to see the response come back as a questionnaire. So one of the real-time benefits of this is that instead of having to go back and forth and exchange information, we've had a real-time questionnaire pop up for that referral coordinator, answer a couple of questions, submit that, and get that auth real time. If you think about that process as it exists today or prior to automation or integration, that might be submitting an authorization, a fax or an email, or maybe even a piece of paper that gets sent back. That response gets created and then sent back to the payer, really wasting critical time, depending on what you're trying to get a prior auth for, and getting that patient scheduled. Because as an academic medical center, we have a fairly impacted group of specialists that are calendaring out for a decent amount into the future. And the quicker we can get that authorization, the quicker we can get that scheduling process happening, and the quicker we get that patient in. And so that first demonstrated that the Da Vinci implementation guide, the integration with a payer and provider, a direct integration, works real time in a way that is manageable within the framework and the platform of both the payer and the provider organizations. Our second use case was with a company called Z Omega. That's kind of on the right, where we worked together with Da Vinci and Centene and leveraged Z Omega as part of one of the partners. And what Z Omega had done is eased additional burdens on the provider side. Luckily, here at UC Davis, we have a fairly sophisticated and complex technology stack. Not super complex and but it's enough that it can do a lot of different things that you might not be dependent or want to be dependent on your EHR vendor for. What Z Omega did was it brought a Smart on FHIR app into the equation and helped standardize that implementation so that the plug and play aspect of what happens within your EHR is very straightforward for just like any other Smart on FHIR app that you might deploy in your organization, and really kind of normalize that activity and then handled a lot of that traffic and back and forth inside the Z Omega platform. And that was essentially use case 2. And then as we get to use case 3, if you could move to the next slide, Samir. Alex, sorry. I'm going to put my shades on. We're at the top with the Trebuchet project. For those of you who don't know what a trebuchet is, our slide here includes a image of what that is, but we've really heaved the ball over the wall into the next stratosphere of integration by networked FHIR. And I think so the future's so bright here, I had to wear shades as the song goes. So I'll put those aside, got my props. But really what we're looking at here, and one of the things that people in the industry and are talking about from an interrupt standpoint is that, well, there's all this FHIR standard and then it's not really being used. And why is it not being used? I'll tell you, at my organization, we process probably 1 million to 2 million FHIR resource requests a month, if not more, for different smart on FHIR applications and different FHIR uses inside of our organization or with applications in our infrastructure or essentially in our network. What Trebuchet does and what the partnership with eHealth Exchange and Cambia and Regents does is it actually deploys a networked FHIR that allows a scalable security framework with a smart on FHIR application that enables all of the pieces of the DaVinci use case and does that at scale, so that instead of negotiating point-to-point endpoint connections and the security related to an individual provider or payer organization negotiating that exchange, eHealth Exchange and the Trebuchet network basically brings that together, allows for the security agreement and the security technology to be in one place, delivered to your organization in a smart on FHIR package, and it allows for you to look at a group of organizations that have agreed to participate in this exchange for this prior auth use case. Even though that hasn't been moved into production, class was so inspired and in awe of what had been built and kind of the deployment and the strategy around that the project itself was submitted and won a Class Points of Light award. There were about 30 to 35 projects that received a Point of Light award from payer and provider communities at the Class Payer Provider Summit last month. And luckily, by the voting that occurred there on site at Class, the Trebuchet project was actually one of the top 4 projects that was submitted to Class and was the Peak Award winner. And if I was to reach over here in my door, I could actually show you the award that's being held there at Jay Nakashima from eHealth Exchange, hands in the picture on the bottom right. So a lot of collaboration, a lot of work going into making this successful, but it tells you that the power of FHIR is there, the power of this interoperability works, and really, there are other HL7 accelerators like DaVinci, like the FHIR at Scale FAST project that are trying to push these standards out into the community and allow for that to scale. What eHealth Exchange and what this project has done is really jump the shark, or the shark's not the wrong term because that's going the wrong way, but it's really jumped forward. It's moved us past from the peak of excitement, past the trough of disillusionment into real implementation and real activity in the marketplace. And so we've jumped that chasm of disillusionment right into a place where we can implement something successfully. And I know eHealth Exchange and the rest of the participants are looking to do that with any organization that would like to onboard. So I think that's it for me, unless you'd like me to put the shades back on, answer questions, but I'm good.
You're
Back
so
to you,
cool,
Matt.
but I am going to go ahead and turn off the screen share because I think you guys are going to now have some panel discussion.
Great. Thanks, Alex. And Michael and Samira, thanks for, again, your commitment and excellent and executive summary and overviews. Before we get to some of the panelists, or I'm sorry, get to some of the audience questions, I have some questions for you all. But again, while I'm talking to Michael and Samira, I encourage those that are on the line to think about their questions, what they've heard. Did I go too fast in a particular area? You want me to drill down a little bit, or a probe for Michael or Samira as well that you want to hear a little bit more about? So please put it in the Q&A function of the Zoom call for questions for Michael and Samira. I'm going to start us off and get us warmed up a little bit. And so Michael, I'm going to start with you and do a little bit more of an in-depth exploration. And I think I'm going to probably go on some of these things. But as you looked at what you were doing and the challenges you were facing while you're pushing those boundaries to engage your business and technical partners, and even like the partners you showed on your one slide, how did you get them engaged, and how do you overcome some of the barriers? Because again, the complex system that I operate with, the 33 companies that we work with from the association standpoint, I have some different challenges. I'm curious from your perspective of being in the local communities, and same for you, Samira. How do you overcome some of those challenges when you're pushing those boundaries? And a lot of the stuff was never done before. So can you guys talk a little bit about that? Mike, if you could start out with that.
For sure. I mean, I think that the big thing is that here at UC Davis, we've really been at adopting and kind of leading out in the community. So in a lot of different areas, we're looking to be a leader in adopting standards and really being the voice of, we work with a lot of FQHCs here in Sacramento and a lot of organizations that don't have the resources or technical competence to kind of adopt the new technology. So part of what we're trying to do is pave the way for those organizations, and that's just part of the culture here. I think also operationally, we're all working with very small margins, and so a real if you follow our CEO on LinkedIn, he'll say AI does everything. AI means a lot of different things to a lot of people. For me, it means automation. It means a lot that there are processes and integration that we can deploy that help make processes work better or more efficiently or quicker than they have in the past. And I think that those efficiencies, whether it's for RPA, robotic process automation, and it's not really a robot, but the process automation, rules-based process automation, or natural language processing, moving things off of paper, OCR technology that allows for you to take some of those things and again, make them usable, discrete data within your systems. I think that all those things are things that we're looking to adopt to allow for the human resource that we have, the limited human resources that we have, work at, back to kind of using a provider paradigm, the top of their license, right? Is we're really trying to get people, our human capital, to work at the top of their capability and not worry about faxing and keyboard stuff and on those sorts of things. So from our standpoint, where we can implement automation, where we can remove some of those administrative burdens or those tasks that are lower level tasks that can be automated with limited to no risk, and really kind of, again, upskill everybody to a higher level to include more complex claims, more complex authorization processes, are really things that our organization is pushing. So the operational piece wasn't difficult. I think my most difficult piece at the moment is just finding the right payer partners in the community that are ready for this. Because most of the time, especially for EPA, their side of the equation is much harder than mine. I have one of their members who needs a particular procedure, and we're going to submit whatever documentation we can do today, manually or in an automated fashion, to get them to authorize that so that we can move forward. Because it's a lot harder to perform a procedure and get denied the claim because we didn't get an auth than to ask for one, right? So all those things are part of the organizational culture, the strategy around moving forward with this technology, and really why adoption for us is really important.
Great. Thanks, Michael. And Samira, I'm going to,
yeah.
And Michael, I'm happy to talk to you offline. We have two plans in California, so maybe.
Bring it. Let's go.
I'll take them as well. I'll take them.
Yeah, it's Samira. I know I've been talking to you about that. So building off of Michael's response, with the Da Vinci use cases, and some of the challenges associated, how did you get your colleagues? So Michael talked a little bit about how he approached it, but Samira, how did you, your leadership, both, whether it's, some of the frontline leaders, but also some of your senior leadership, because some of the stuff, like I said, is unproven. Curious on some of the tactics, because those on the call may be early in this journey and saying, hey, I want to do some of the things that Providence and UC Davis are doing. How can I do that in my organization?
Yeah, I love that question. And I'll put my value-based care hat on, because I think Marchant did a really good job at tackling like the broad exchange. Like anyone who goes and has a procedure needs a prior authorization. That's, well, if the procedure warrants it. And I think that's extremely important. And I think the world of value-based care has its own intricacies, right? And so I want to split my answer into two or maybe three sides. The first one is other provider organizations. So like UC Davis, Providence is pretty high tech, right? We're a large health system across 7 states. We have about 50 hospitals, about 1,000 clinics. There's a lot happening, almost 200 value-based care contracts and so forth. And so I think we fully acknowledge that what we do is not always feasible for every single provider organization. And what we also acknowledge is that as a provider group, you don't know what you don't know. If you have a value-based care contract and you have, someone in your clinic who goes into the portal, who gets the enrollment data, who then says, no, I know that these 5 patients had colonoscopies, and then goes off and, looks at the chart and then goes back and follows this manual process, you likely don't know any differently. Like, you think that this is how the process needs to work and that this person's job needs to consist of that. And maybe you've heard about AI a little bit and you're thinking, oh, maybe there's some opportunity for automation, but you likely don't know any differently. And so when it comes to expanding to new value-based care contracts, or advocating for the kind of information that you need, and advocating for your HI, IT, whatever teams to be able to build something out that would be beneficial towards, to your point, Matt, earlier, creating this ecosystem that fosters bidirectional data exchange and as real time as possible, right? If you don't know, you don't know what to ask for. And that's one of the reasons why, Providence, UC Davis, Multicare, why we're out there sharing our story and saying, get in touch with us. If you need help in figuring out how to get funding from your executives, let's talk about that. Let's talk about the kind of analysis that we do that says, here's the value of submitting supplemental data. Let's talk about the value of ASN and how you quantify that and how you're able to get funding from essentially some of those processes that you already manually support to be able to build out some of this. Or if you need help from vendors or whatever it may be, right? So that first piece and how we get other providers to see the value in this, it's really by just putting ourselves out there and saying, we have crawled through this process. Here's where we needed help. Here's what we would have done differently. Let's collaborate. And then ensuring that those same provider groups can engage with us, can pick up on this, and can run where we were crawling.
Great.
The other side.
Oh, good.
Yeah.
Michael, anything you want to follow up on there? Anything on that one?
No, I think Samir answered it perfectly.
Right. Michael, how about, building off, the automation, and I'm almost 40-year member of HEMA, and I'm HIM professional. So the workforce impact. So all this automation, it's going to put people out of work. What are your thoughts about, some of the considerations we should be thinking about in our profession, in my profession, and also across the industry of what's going to happen with some of this automation? Can you elaborate a little bit about your thoughts and pontificate a little bit on? And I know we've had some offline conversations on this before.
I'm sorry, what specifically were you?
So the impact, so the automation and the workforce impact, okay. And like if you're trying to engage, your HIM manager or your folks that do the revenue cycle management, well, wait a second, as I love, Samir, how you do this, and I see this in other parts of the payer industry as well. Well, this has been working this way really solid for 20 years. You want me to really change something that's been working really good? And then also the way when we do it, we're gonna reduce, we're gonna lose some of this workforce. But Mike and Samir, can you guys talk about that a little bit?
Yeah, I mean, I think that the big thing and what's been nice, Matt, is that we've had a really good partnership with our HIM folks for a while. Our team at Davis does a lot of coding. So we spent about 18 months implementing some automated coding tools with 3M and working through kind of what automation does. And again, back to that upskilling, right, is really trying to make sure that the staff that we do have, that human capital, is working in a way that is most beneficial to the organization, and really trying to automate those lower level tasks. So really building that corollary of, these are things you do today. You send faxes, you scrub websites, you do phone calls, you do a lot of these things that are not value add organizationally, and really talking to them about what this automation looks like when it comes to referrals, when it comes to lowering claims denied. Or part of the numbers that we've seen out there is that more than half of the auths submitted don't require an auth, right? So because we believe, and again, this is back to the disconnect, and I'll make a small plug, as I always do when I talk about this, for shared contracts or smart contracts and blockchain technology. Because what happens is you agree to a contract on paper with the provider and the payer agree to a contract, and then they go build their separate versions of that. And then because the provider is so conservative in their interpretation of the contract, because they don't want to get claims denied for not being auth, they build rules to require auth even when it's not required. So now we're doing more processes. And think about that. If I have a paper process that doesn't require auth, I've delayed care and done more work than I have to do in the first place because of that conservative nature. So you really tie those things together, and there's plenty of industry, lots of industry information that's out there that tells you about the amount of time and that it takes to do that auth. And again, another piece, and again, I haven't done the I'm not an actuary, so I can't do the financial on this, but if you're a patient with a particular condition and it takes 6 weeks to get an auth and takes another 90 days to get an appointment, what happens to your condition in that
Right.
4-month period of time, and what other care might you need that if you had received care in a reasonable amount of time, given the limitations around specialists, that your condition might not have carried on to that point. I mean, there was an article in Becker's about sepsis, and we've implemented some AI at UC Davis around sepsis detection. It's an art. It's not a science. There's lots of different biometric factors and information, and the system is trying to provide that information to better care for patients. And I think that's where you have to look at it. Is it doesn't solve all the problems. It doesn't find everything, and it's not perfect. But what it does do is it takes all those routine and mundane things and tries to eliminate them. And I think that's where our HIM friends see the benefits of this implementation.
Great, thanks, Michael. And Samira, anything you want to add? But I know we've got a couple of questions in the Q&A, and I know Alex is going to take us through those. But Samira, anything you want to add? Just in terms of the automation and how you see that impact and all that.
Yes, just really quickly, and I love what you said, Marchant, because I do think that when we think about HIM, typically people think about like chart requests and processing those requests and the cost associated with those. I saw somewhere that the average cost is about $35 to $50 per each, at least HEDIS-related chart piece, right? Our HIM teams have much more important things to do than to rush to just package things up and fax them back or mail them or whatever it may be. And a lot of this work will just allow them to scale out to new things that they can focus on. To Marchant's point, focus on new things that are more, that are utilizing their skills in the best way possible. So besides maybe ditto Marchant, I have nothing else to add on to this. I will say though, you had a prior question, Matt, regarding just working with providers and payers in the community and so forth. And I didn't get a chance to talk about the payer side of things because payer readiness is a really big thing as well, right? So if you have a payer partnership, you cannot force your payers just to implement an entire, API ecosystem. A lot of our payer partners are already working really hard to meet specific mandates associated with prior authorization or peer-to-peer exchange or provider access API now, patient access API, all that stuff. And so approaching your payer partners and saying, hey, now you need to get all of the enrollment data and FHIR to me. I want claim line level detail. I want financials and all this stuff. It just doesn't happen overnight. And so I think it's really important that throughout this entire process, we say, what can we support and how do we support it? Maybe we're going to have better success implementing CDEX if we come to the table and we say, here's the data you're getting currently, here's what it's going to look like, here's why that's so important. Maybe we can have better success implementing PDEX, right? Especially for commercial plans that are not mandated to do so, by saying, if you share clinical data with us, it means we have to do less outreach. Let's share some information about that. If we can get claim line level detail with the associated financials, because we have a total cost of care contract, maybe we can lower spend by 5%, whatever it may be. And so in all of these conversations, it really is about partnership. It really is about trust. It really is about building that ecosystem where we're understanding what our capabilities are across the board, and we also understand what the limitations are, and then building a plan accordingly.
Thank you. Thanks for the follow-up there. And Alex, I think one question probably could go to Michael, one could go to Samira based on how I'm seeing it.
Yes, actually, we could. But before I do that, I want to first share my screen to answer a question that we sort of handled a little bit offline, but I think it might be interest to everyone. We were asked about how can people get involved with the Da Vinci Project, and we were always open to new members. We have details that'll be a part of the appendix when we post these slides tomorrow, and also are available on our Confluence space that talk about membership opportunities at various levels. And the other thing I wanted to showcase was that beyond the membership opportunity that really gives you the chance to influence the trajectory of the project, you also have, as industry, an opportunity to join any of the use case working group calls. There's a list here, as I'm showing, of all the conference call schedule that we have. We also have the ability for folks to access our meeting minutes. Everything is very transparent and publicly available. We also have the opportunity for folks to, beyond membership and sitting on use case calls, you can participate in the ballots on the implementation guides. We need all kinds of experts from the continuum of healthcare to participate in the various points of standards development, because it makes a difference in the end product by having all those different nuances taken into account, whether it's behavioral or physical health, mental health. It's important for us to have as many participants at the table as possible. So I encourage you to take a look at that if you're interested in membership or just general call participation. There's a plan for you that'll work in the Da Vinci realm and HL7 community.
The Da Vinci realm, what are we in the MCU? What's going on here, Alex?
Well, maybe I've watched a little too many Marvel movies lately. Anyway, so I want to ask a couple of pointed questions that came in. The first question was related to understanding how this effort has affected net new contracting and templatization of further upstream. So I'm not sure if this is really towards you, Samira, or
Probably more Samira than me, for sure.
Michael. Yeah, because they also want to understand not only about your net new contracting opportunities, but the readiness spectrum among your payer partners and for their functionality.
So I go back to saying I'm part of Providence, so we have a lot of contracts. Does this process in general allow you to be able to scale out to new agreements because it allows you to have a better understanding of what your value-based care contracts are, how you can succeed, how you can build the partnerships? Absolutely, right? If you can see that something works within one line of business and you can scale out to another, and you have an opportunity to partner with other payers, this could absolutely help. I say that cautiously only because Providence is a large organization, and so we already have a process in place to, contract in all of our markets. And that second piece about the question about readiness, I think that goes back to what I answered just a few minutes ago. It really, really depends on the market. It depends on whether there are any regulatory, whether it be state or federal requirements. Think about prior authorization, think about the provider access, patient access, payer-to-payer APIs, and so forth. If you have a Medicare Advantage plan or Medicaid or CHIP or whatever it may be, you have a specific deadline that you have to build something until. And if you're not offering those kinds of plans, you're less likely to adopt this, right? And I think that's where that partnership piece comes into place. Even if you only offer commercial services, but you are contracted with 20 providers, it is in your best interest as a payer to be able to implement something based off of standards, and then to be able to work with your providers to execute, to scale out, and so forth. And so readiness is really just all around the board. And I think that's why I make it a point to keep honing on the fact that this is a partnership process, right? This isn't anyone demanding that someone build out a use case just because we think it's cool or whatever it may be. This really is a path towards saying, what can we as an industry do to make this process work? Why is it beneficial? What are the financial opportunities? What are the patient opportunities, and so forth? And so it's all over the board right now, but I imagine over the next 5 to 6 years or so, especially as some of these mandates come to pass after 2027, so many of our payer partners will have that foundation laid out, right? And one of the magical things about FHIR is that reuse, recycle component, where we all speak the same language. Security is the same across the board for API usage and so forth. So I anticipate that after 2027, a lot of this will pick up a lot faster. But do not quote me on that, because I do not have a crystal ball. Those are just my feelings at this point in time.
0057, Samira. Electronic prior auth required. We got to drop in the 00. For those of you who aren't familiar, the HHS came up with a requirement that electronic prior auth will be required.
Right.
And that's 0057, which we think sounds like a spy, James Bond. We got to come up with a new name for
that was intentional.
Yeah. So.
All right, excellent. And I think it also, Samira, you underscore sort of the process that we have in Da Vinci, in that we take on use cases that have broad membership support and are going to provide that type of reusability and value proposition. We don't invest in things that that don't have that sort of groundswell support of the membership that really people say, aha, this is going to make a difference. And that's why we pick the use cases we do. And then we thoughtfully mature them from a discovery project all the way to normative as a commitment before we're going to hand it back into HL7, and that we're continuing to be mindful about what we add into our stable of work so that we can really fulfill the commitments we have so far. All right, so let me ask the next question, which is related to the prior authorization implementation demonstrated. First of all, there was a kudos provided for being among the first. And the question is, did you have to do additional mapping to match up the payer and provider side clinical criteria? Were the clinical guidelines managed by the same vendor in this scenario? And how long did it take to complete end-to-end implementation?
Well, I'll talk about, at least if Samir's okay, if I'll talk about our implementation. The the work that we did with Centene was the most robust in that respect. And again, as I said earlier, the provider side was a lot pretty easy, is that we were submitting them the request. And if you think about the FHIR resources and transactions, is we would submit the request for the authorization, and depending on what that request required, part of the essentially assessment or a review of that request and that member and that contract, the payer then comes back and retrieves the resources, the FHIR resources, i.e. documents and data that they need in order to support that request, whether it's pulling in back a lab report or what it might, or a progress note or something like that, or like I talked about earlier as well, pushing back a questionnaire that our referral coordinator completed. So the complexity really, from the most part, is on the payer side, because we're going to submit requests for a particular procedure. They're going to have to match that up and then respond appropriately, whether that's a request for additional documentation, pushing a questionnaire, and that mapping is handled on their side. Now, we're still talking the same language when we talk about FHIR resources. So the problems or meds or allergies or documents, those resources are all the same. So from that standpoint, there is a standard that we're leveraging. And if you're familiar yourself with the implementation guide around CDEX and PDEX and all the other acronym soup that we throw around, it has a lot of those mapping pieces in place, so that part is part of the implementation guide. But from a pure tech play or pure tech standpoint, is we build the channel, we implement the channel correctly, and then provider submits information, payer may request information or respond with information, all of which within that framework. And for us, from start to finish on the first one, it was probably 9 months, and most of that was really, I'm a stickler for requirements gathering. The technical pieces aren't difficult because most of the tech exists. Your problem is when you implement it, you want to implement it a certain way, and you want to make sure you meet all the requirements. And if you don't spend the time up front, you just spend your time technically churning and testing on the back end. And so, we spent a lot of time meeting and building business requirements up front. We decided that we were going to do 5 particular procedures and use cases, so we didn't have to program for the whole world, but could make sure the plumbing was working under different circumstances, again, to include the questionnaire. So really, depending on how prepared you are and if you've done it before, because number 1 was 6 months or 9 months. Number 2 was probably 3 months, and the eHealth Exchange one we did was probably less than a month. Now, again, from a work time standpoint, it was probably a little long, or from a calendar time standpoint, it was probably a little bit longer than that. But it was probably a few weeks worth of work and some testing, and we were ready to rock and roll. So, again, repeating things and leveraging standards and doing things consistently across implementations. The more you do it, the better you get, and the quicker it comes, and your partners also become more knowledgeable as they're implementing it as well. I know, Samir, anything from your side?
No, I totally agree with all of that. Nothing else.
Yeah, I think it's Matt. Do you want to add anything from the payer automating or digitizing their clinical guidelines for prior authorization? Oh, I think you're on mute.
Thanks, Alex. I'm thinking I'm more curious about some of the other questions in there, but that from the audience. But definitely from a payer perspective, we have 33 organizations that we support, and as you guys can imagine, just like you that have multiple hospitals in your system, you've got some that are on the various learning curves. But definitely the capability to automate much more and do faster prior authorization. Again, wanting to get patients and members to the care that they need, that they appropriately need, right? I mean, that's what we want to make sure, because we want good care, that's appropriate care, that's affordable, and we get the outcome that we want. And Mike, I loved your example of just that, you know, the urgency and the time span that happens with some of the delays. I think it's a really, you know, something that I want to, you know, make sure that we can try to reduce and prevent you know, that hassle and that delay for a member and all. But Alex, I'm there's some really excellent
I
questions.
want to ask the last question
Yeah,
about
that was the one that was sorry.
the low-hanging fruit functionality that feels like an easier pitch for technical perspective, or is from an incentive alignment perspective, that you would recommend for less mature geographies to lead with? So if you were going to go do a pitch, what would you?
I'm going to point at Samira. I'm pointing at
I'm so biased. I am biased, but the ATR CDEX combination, because if you have quality measures that are impacting your total payout on a contract, right? One, you can quantify that right away. Oh gosh, I gave it a thumbs up. You can quantify that right away. You're already on the hook to do this work. You already need to be able to submit the data and to exchange information bidirectionally. Like, that is just your biggest win with, I would say, less effort than what prior authorization may entail. Obviously, it's different if you're a payer or provider, and Marchant, please feel free to push back. But I just think if you're looking for something that drives revenue, that has an impact on outreach when it comes to, you know, referral coordinators, patient care, whatever it is, that can allow you to automate and scale like your everyday processes, that is a big thing. I think next would be obviously like a focus on risk adjustment and gaps in care and stuff like that. But because you build this foundation with ATR and you're utilizing, I'll say 70%, but that's probably a wrong thing. The same kind of resources, you're already accustomed to that data. You scale it to CDEX, and you can see that impact right away. And one of the best ways to see that impact right away is to go back out to your payers and say, hey, when you're ingesting my legacy data or looking at data through the portals and you're looking at what you're getting through FHIR, what is the impact? Are you getting more clinical data? Are we closing more gaps? What is the measure lift, and so forth? So if you're interested in talking about that, please reach out to us, because that's a really good area to get involved in.
Alex, just to tag on that, I know we're running out of time, but our esteemed colleague, Dave Degani, that was his drum. He would always say, you want it, I've been down the road. If you start with the attribution, the ATR, that is there's no easy path to anything that we do in our business, but it's one of the more softer ones that, you know, for our questionnaire, the low hanging fruit.
Yeah. Get familiar with FHIR. It's here. It's coming. It's big. It's impactful. And I think that you know, if for you at an organization that might not be as far down the road, or in a geography like California where the state is forcing us to do some of this stuff, you know, again, just expose yourself to the technology and find a good partner that's willing to apply resources and learn together. If you can't, you know, you can't do this alone. Interoperability is not a one-way street. You need a partner. You need a good partner that's willing to take the risk and the jump with you and move forward. And when you have that, you can be successful, and then you can replicate. And I would tell you, find something of value to your organization to move forward with a partner that's a valued partner and willing to apply resources, and you can be successful.
That's great advice. And I think it's also important to understand that when you look at federal rules related to 21st Century Cures Act and patient access interoperability objectives, as well as the other rules from CMS like 0057, there are a lot of building blocks out there already. And today's presenters are leading edge innovators, really forging the path forward in the experiences that are proving out the work that we're doing with FHIR. But it is becoming very commonplace, and over the next handful of years, we will continue to have more and more FHIR exchanges, in addition to the other HIPAA exchanges that we already have today, because we live in a world of multiple standards, and that's going to be the norm. There's the award. All right, you're on mute.
I know I didn't wait. Award-winning innovators. That's what award-winning. I just had to roll over to get my thing. So anyway.
Awesome.
Thanks, everybody. Always fun.
It is. Thank you so very much. Please complete the survey and join us back in August as we will be taking a hiatus in July. Enjoy the summer. See you in
Thank you,
August.
everyone.
Take care, everybody.
Thanks. Bye-bye.
Bye.
Terrific session, guys. Thank you.